Production and distribution of City Club forums on IdeaStream are made possible by the generous support of PNC and the Raskin Family Fund, with additional funding from Robert Conrad, Cleveland State University, the Chautauqua Institution, the Cleveland Clinic, and the United Black Fund of Greater Cleveland, Incorporated.
Ooh, that works. Good afternoon. Welcome to the City Club of Cleveland. I'm Keith Libman, past board chair of the Mount Sinai Healthcare Foundation. Okay, thank you. I'm still Keith Libman. And I'm pleased to introduce to you today our speaker, Dr. David Olds. Dr. Olds is the founder of Nurse Family Partnership and director of the Prevention Research Center for Family and Child Health at University of Colorado Anschutz Medical Campus. Infant mortality, defined as the death of a baby before his or her first birthday, has declined 15% between 2004 and 2015, according to a report from the Centers for Disease Control and Prevention's National Center for Health Statistics. However, that statistic does not tell the whole story, as we've already heard. According to a 2017 study published by the Pediatric Journal of the American Medical Association, the mortality rate of African American babies remains at least twice that of white babies, and overall progress in reducing these rates has stalled. Other studies have shown equally sobering statistics, such as a decline in birth weight, a condition putting these children at risk for developing life-threatening health problems. The racial disparity is particularly evident here in Cuyahoga County. According to a recent report, African American infants die at a rate 6 times higher than white infants, and Bernie and I must have had the same source of information, so good for us. The rate of low birth weight babies in Cuyahoga County is 11%, the highest of all Ohio counties. There are many programs at the local, state, and national level aimed at reducing infant mortality, as well as other racial disparities in medicine. We're going to hear about one such program today. Dr. Olds has devoted his career to investigating methods of preventing health and developmental problems in children and parents from low-income families. He created the framework of what has become Nurse Family Partnership, also known as NFP, in the 1970s after working at an inner-city daycare where he cared for preschoolers experiencing trauma and poverty. He quickly came to understand that even at that young age, it was often too late to provide the interventions that would be required to improve the chances for a successful life trajectory for the children and their parents. NFP brings specially trained nurses to visit first-time Medicaid-eligible mothers in their homes from the time of pregnancy until the time their child is 2 years old. Repeated research has shown that the program benefits not only the children who experience greater overall physical and emotional health, but also their parents. Today, NFP serves low-income, first-time moms and their babies in 42 states, the U.S. Virgin Islands, and 6 tribal communities. NFP is active in our community. The program was recently brought to Cleveland by the Mount Sinai Healthcare Foundation and its many public and private sector partners, and is operated at Metro Health Medical Center. In addition to his work with NFP, Dr. Olds is a professor of pediatrics, psychiatry, and preventive medicine at the University of Colorado Health Sciences Center and director of the Prevention Research Center for Family and Child Health. He received his BA from Johns Hopkins University and his Ph.D. from Cornell. Dr. Olds is one of us, a local boy from Conneaut, Ohio. When he spoke last night to the Mount Sinai annual meetings, his remarks were riveting and insightful. After his prepared remarks, he had so energized the audience that poor Dr. Olds was blocked at every turn with people who wanted to continue to engage with him about the NFP program. and the implications that it has for making massive societal changes. And sadly, the poor man never got to eat his dinner, so I'm sure lunch was appreciated today. Ladies and gentlemen, members and friends of the City Club of Cleveland, please join me in welcoming Dr. David Olds.
Thank you. Thank you for that warm introduction, Keith, and thank you, City Club, for inviting me here this afternoon. I feel that in so many ways we have shared missions. Those of us in this room, I know, are committed to using information, the best information available to guide public decision-making, and we need to develop information to make improvements in the lives of our citizens, but maybe especially those who are vulnerable. And it's that segment of the population that the Nurse-Family Partnership is focused on helping. I feel really honored for many reasons to be aligned with you at the Mount Sinai Foundation, Metro Health, and other community organizations in trying to address not only infant mortality, but all of the other sequelae that are associated with growing up and living in poverty. You know, I come to this work in some ways with personal experience, with personal ties to having grown up with limited means. My mother worked in a factory in Conneaut. It was a single parent, essentially. My grandmother, who managed the care of her children in the Depression, lived in a house with no running water, no electricity. The adversities that come with those kinds of living experiences my family experienced, but I also know how crucial it is to have caring parents and grandparents, because those kinds of social supports and connections can buffer the challenging experiences of having very little to manage with. So I was really fortunate, as Keith mentioned, in receiving a scholarship to go to Johns Hopkins when I graduated from high school. And I was going to go into international relations because I thought that I was going to do work to save poor children in Africa and India. And I was recruited into their School for Advanced International Studies to work on international relations. And I thought, oh, this is a great context for being able to fulfill that kind of emergent vision that I had for myself and for making a contribution. But soon I realized that I was going to be involved in figuring out international power politics and international economics. We were in the middle of the Cold War, and I went to Baltimore in 1966. And guess what? That was the middle of the counterculture and all of those huge periods of social disruption and anguish that was going on in our society. So I dropped out of this international relations program and developed an interest in developmental psychology. And when I finished up undergraduate school, I went to work at the Union Square Daycare Center on West Lombard Street. It was a program for poor families living on the west side of Baltimore. The families served were both African American and poor Appalachian families. And it didn't take too long for me to realize that I have to say that I started this work at the Union Square Daycare Center with the expectation that I was going to somehow save the world by interacting with poor children and their families. But it didn't take me very long to realize that for many of the children in my classroom, it was both too little and too late. One little boy in my classroom couldn't function. He couldn't speak. He was clearly developmentally compromised. His mother had been a drug addict and an alcoholic, and she had abandoned him to friends in the drug culture. Eventually, his grandmother took over his care, and it was in that context that I got to know him. Another little boy in my classroom couldn't sleep at nap time. And what I discovered was that he couldn't sleep at nap time because when he slept, he wet himself. And he said that if he wet himself, his mom would beat him. So for him, it was safer not to sleep at all. I witnessed children being slapped up across the face, yelled at, and pushed in the front door of our center. So I felt, we need to do something with parents to really help make a difference with parents. So I created a parent group meeting where parents would come into the center while the children slept, and we would have a chance to talk about their developmental needs. The striking thing, though, was that it was the parents of the children that I was least concerned about who showed up. It was the parents that the children I was most concerned about. I never saw their parents. So it struck me that we needed to start earlier. But also, if you walked outside of the door of our center, the community context for parents to protect themselves or to protect their children were totally unacceptable. The rates, at our center, there was a big focus on helping children and families eat healthy diets. But there were no supermarkets or markets of any sort within miles of the center that would sell fresh fruits or vegetables. What they had was a corner grocery store, or a corner store that sold Twinkies and canned goods on a corner right across the street from us. The park where I would take children for playtime there were needles on the ground, there were alcoholics in the park. One Easter, we dyed Easter eggs, and I took them over to the park where the children stayed back at the center, and I was hiding them. And what was striking was that there was this poor mother pushing a baby cart through the park with a preschooler running alongside the baby carriage. And when I put the eggs down, she would point to the eggs, and this preschooler would run over and grab the eggs, bring them back, and put them in the baby carriage. That level of poverty. There were alcoholics there with long trench coats. They also, as I was distributing the eggs, would come over and pick up the eggs and stick it in their pockets. The levels of poverty were just totally unacceptable. The housing stock was terrible. The rates of crime were off the charts. I had my car stoned on the way to work. Trying to care for oneself or one's child in those kinds of conditions is totally is just unacceptable. When someone said before these are issues regarding racism and classism, that's true. That's true. But nevertheless, our team, after finishing graduate school, I led a team that designed what's known today as Inter-Family Partnership. This is a program of prenatal and infant and toddler home visiting by nurses for low-income mothers having their first babies. We focus on that segment of the population, first of all, because low-income mothers have a concentration of adversities that make it more difficult for them to protect themselves and their children. But focusing on women having their first pregnancies is also critical because we thought at the time we began this work, it would be critical because women are going through major life transitions in their roles that make them increase their sense of vulnerability and their receptivity to offers of help. But now we know that not only are women going through major transformations in their roles in society, but they're also going through profound neurobiologic changes that, from an evolutionary perspective, are designed to help parents fulfill this responsibility to protect and promote the health of their babies. So, in a way, the program is leveraging that underlying human instinct to protect our children. The The nurses have three major goals. The first is to help women improve the outcomes of pregnancy by helping them improve their prenatal health, cutting down on the use of tobacco, alcohol, illegal drugs, identifying emerging obstetric complications, and to help women identify those obstetric complications and have them treated more responsibly and promptly through sources of primary care. The second is to help parents promote their children's health and development by learning how to provide sensitive, responsive, growth-promoting care to their children. And the third is to help women improve their own health and their economic self-sufficiency by imagining what life might be like for themselves and for their children, and to make wise choices about the timing of subsequent pregnancies, finishing their educations, finding work. All of those pieces are designed to promote maternal health and economic self-sufficiency. In addition to this, the program systematically involves fathers and grandmothers and other concerned family members to create a cohesive, supportive family environment. And also nurses get to know families deeply and to make sure that their needs are, their survival needs, are being addressed through other health and human services in the community, whether we're talking about housing, mental health services, substance abuse treatment services, right on down the list. Those are the key elements of the program. Now, we've taken the position that this program needs to be tested rigorously. We have tested it in 3 separate randomized clinical trials over the last 40 years. These are the kinds of research designs that the FDA requires of new drugs and medical devices. And honestly, this is hard work to do in complex community settings. We first examined the impact of the program in Elmira, New York, a small semi-rural community with a primarily white sample. Many of the results of the program were really promising, and people said to us, gee, you need to make this program more widely available. We took the position that we ought not to do that we needed to know whether the program would work with minorities, especially African Americans living in major urban areas. So we held off for offering up the program for public investment until we conducted a large trial of the program in Memphis, Tennessee, with families that were really disadvantaged, living in really challenging neighborhoods. And then more recently, we have tested the program with a large sample of Hispanic families living in the greater Denver metro area, where we systematically compared the relative impact of the program when delivered by nurses versus paraprofessional or community health workers compared to a randomly assigned control group. Now, I want to share with you some of the key findings from these trials, but before I do this, I want to help you understand what nurses do by just describing a case. One young mother came to her first home visit in a house coat, smoking cigarettes, and she was visibly depressed. And when the nurse asked her whether she was planning to cut down on cigarette smoking now that she was pregnant, her response was, you know, this baby's taken everything else away from me, and it's not going to take my cigarettes away too. You know, if you say anything else that I don't like, I'm going to slap you up across the face. You think I'm kidding? I broke a couple of my mother's ribs in a fight just last week. And this mother went on to reveal that she had been tortured as a child. And critically, she said, I'm afraid that I'm going to do this to my own child. That is the entry point for developing a constructive relationship with a mother around protecting her child. All these other things, of course, were major issues. But what the nurse focused on was this mother's desire to protect her child, in spite of all this other stuff. And she went on, by the way, with the nurse's help, to manage the care of her child remarkably well. And you know, many people who have observed the nurse-family partnership have said things, thanks. I get carried away, have said, you know, the nurses in this program are heroes. And I agree with that. But if you talk to the nurses, what they'll say is that, yeah, we're doing good work, but it's the mothers and fathers often who have experienced terrible adversities who are the real heroes in all of this, because they're overcoming this history of adversity and current challenge to really do what's in the best interest of their child. When we began this work, many people said to me, you know something, this is a waste of time. We're dealing with deep class divisions, deep racial and economic disparities. How is a program like this going to make a difference? And my attitude was, we don't know whether it's really going to work or not, but we need to give it a shot. We have a responsibility to try this. And so that's the position we've taken from day one. We need to have something that is clinically well developed. We need to have something that is true to our commitment to being accountable, using the highest scientific standards that we know in the whole field of health and human services. And we need to recognize that we don't have all the answers, that we are on a journey together to get it closer to being right. Now, among the things that we have found, and this is what gives me some hope, it's when you see replicated findings, that is, findings that are produced in not just one trial, but are replicated in other trials, that you start to say, this is real. There is really something going on here. We see consistent effects on prenatal health, especially reductions in prenatal tobacco use, biochemically validated reductions in hypertensive disorders of pregnancy, which have both immediate and long-term effects on the mother's own health and the health and well-being of the baby. We see impacts on the rates of prematurity and low birth weight for at-risk subsamples in our trials. We see consistent effects on injuries, especially, and this is most important, injuries that lead to hospitalizations that are indicative of the children's having been abused or neglected. We see consistent effects on children's language development, mental development, school achievement in math and reading. And these effects are more pronounced for mothers who are children born to mothers who are most vulnerable. And it tells us that this precious resource that we're here to talk about today, and you are supporting here in Cleveland, needs to be focused on those zip codes, those neighborhoods where the needs are greatest and where the families are most vulnerable. The need is great there. It's those families where the rates of mortality among children, and among the babies and the mothers, are unacceptably high. So we also see consistent effects on children's behavioral regulation once they enter school, reductions in substance use early in adolescence, reductions in depression and anxiety on the part of children. And in addition to this, we see for the mothers reductions in behavioral impairment due to their use of substances, reductions in the rates of closely spaced to subsequent pregnancy. That's a reflection, we think, of their belief that life has possibilities for me and for my child, and I'm going to make these efforts to regulate my own behavior to protect my baby. We see consistent increases in employment and reductions in public expenditures for welfare, Medicaid, food stamps, cash assistance welfare that extend over long periods of time. This gives us great hope for the future. And we don't think it's the only solution, but it gives us reason to believe that there is something that can be should be done if we collaborate deeply with parents themselves and with other committed health and human service providers in the community. Are there challenges? As I said before, yes. It was after these findings started replicating that we entertained an invitation from the U.S. Justice Department to set up the program in high crime neighborhoods around the country. And after that, we developed what I think is a thoughtful model for community replication of the program. And that includes things like making sure that the community and organizations for delivery of the program are well prepared and committed to do this work. And that's why I'm so optimistic, by the way, about what you all are doing here in Cleveland, because there is that sense of shared commitment and capacity. And I think the fact that you may not know this, but the Nurse-Family Partnership is integrated into the Metro Health system, where they have the capacity to work with primary care providers in delivering prenatal care and pediatric care. And there are opportunities to engage other health and human service providers in the communities to make sure that the needs of these individual families are being addressed thoroughly. I am, the second major piece of this community replication effort is making sure that nurses are well prepared for this, both in terms of basic education, ongoing consultation, that there is an information system that's used to monitor implementation of the program, and that we collectively can examine these data to see where things are going well and not so well, and to use that information to guide continuous quality improvements in the model. The program, as Keith indicated, is now in 42 states. It's growing, and I think that we are also in 7 other international settings where other countries have come to us and asked to develop the program. We think that the opportunities to learn well within communities, but also to share learning across communities, and that includes the international context, will make us stronger. I had an opportunity to meet with maternal fetal medicine fellows this morning before this talk, and what strikes me is that there is this shared commitment to try to get this right. It's through a sense of, or a genuine commitment to sharing insights and working toward this common purpose that we're going to start to really move the dial on these terrible things that are happening to vulnerable children and families in our society. So I'm very, very honored to be part of this conversation in Cleveland. And we're going to move it forward. We're going to move it forward together. Thank you.
Thank you very much, Dr. Olds. I'm Dan Moulthrop, Chief Executive here of the City Club, and today, stay right here, don't go anywhere. You cannot, you have a role to play. I can't answer the questions. They're going to have questions, and I can't answer them. So we're enjoying a forum today with Dr. David Olds, founder of the Nurse-Family Partnership and director of the Prevention Research Center for Family and Child Health at the University of Colorado Anschutz Medical Campus. We're about to begin the audience Q&A. May we have our first question, please?
Good afternoon. I'm so glad you're here today. In a society where we have 26-year-old grandmothers, it wasn't surprising to hear about the resistance of the young mom that said, you know, this baby's taking everything away from me. I'm not going to let cigarettes take this. But my question is, how did you go from, especially many moms being so young and having your generational poverty, how did you go from that kind of resistance to having a willingness from the moms to really do what was necessary for their baby?
Thank you for that wonderful question, because that really goes right to the heart of this. I think one of the things that in professional circles, I think we are sometimes reluctant to use this word, but the word is love. This nurse and this mother both said, We love one another. This nurse, by listening to this mother and reflecting on her experience and finding practical ways for her to avert the terrible outcomes that she worried about for herself, was able to, and to find practical ways of solving those issues. And there is also, I should say, she found that, and embodied in all of this is a deep sense of respect and caring. Later in life, that mother and the nurse happened to see one another in a shopping center area, and they ran across the shopping center and embraced one another. I think that what we're talking about is something really fundamentally human, and it involves something that goes on between parents and children, but it's something that we all have the capacity to do with one another, and that is to empathize. Most people have the capacity for empathy and respect. And it's in the formation of those human bonds that I think that, I don't think we've fully explored what the possibilities are. I know from some having the opportunity to watch what's happened with the program and to look at the evidence, to become increasingly optimistic about our ability to support those kinds of transformations. Thank you.
The late philanthropist Eugene Lang, who spoke here at the City Club years ago, when he made the commitment to his 6th grade graduating class at PS, whatever it was in New York, that he would pay for college education for every one of the students, there were about 28 of them, who matriculated into college, realized very shortly after he made that commitment that a great deal of individual attention would be required. And he ended up engaging the services of not one but 2 social workers to work with those 28 or so children for the next 6 years. And the results were quite amazing. Something like 25 of them did go to college, and I think 2 of the others went to the military. So my question is, what kind of time or what kind of caseload can your nurses take on and hope to achieve success? It sounds to me like it's one-on-one and with a very limited number of clients that any one nurse can handle during any one month.
Thank you for that another insightful question. And let me just say that I failed to let you know something about just the structure of the program. So I mentioned that nurses begin in pregnancy as early as possible. So much is happening in pregnancy, right? It really is shaping neurologic development and behavioral growth and somatic growth and so forth. Nurses continue with families until age 2. That's the critical thing. And part of it is that, and their caseloads are currently designed to not exceed 25 families per nurse, but they adjust the dosage of the program to the needs of the families. Some families, in spite of their living in terrible circumstances, are actually managing pretty well. They don't need the full dose of the program. Some families, like the young mother I mentioned earlier, need the full dose. And so nurses are using their clinical judgment to adjust both the content and the dosage of the program to fit the particular needs of each family. Nurses follow detailed visit-by-visit guidelines that allow them to think about all of the things that need to be covered to help ensure that this mother and this child are protected and launched, so to speak, to be able to go forward well. There are some circumstances where children really need to be removed from harm's way. I mean, we've had situations where mothers are profoundly mentally ill or have substance abuse disorders, and the nurses have been able to help those mothers make the decision to put their babies up for adoption because they were incapable of really protecting their babies. But they do it with a sense of respect and an approach that is deeply humane with those parents. But ultimately, it's through their how should we say this? Their commitment, their ultimate responsibility to make sure that babies are protected. I could go on about this, but I hope that gives you a little more insight about how the program is structured.
Just to follow up on something I was asking you about earlier, I imagine a program like this has a great deal of potential to help immigrant foreign-born families who have settled in the same new strange place with a person who cares about them actually visiting them at their homes.
Yes. Well, thank you for that. I think that the needs of immigrant families are clearly very high. And at the same time, let me just say this, all of the literature that we have around the health and well-being of immigrant families suggests that immigrant families actually are on average doing pretty well. And that part of it has to do with often the cohesive family structure. That doesn't mean that they don't need the additional support of something like an NFP nurse. But unfortunately, what we see is just developmentally, once immigrant families get integrated into U.S. society, often, too often, some of the behavioral sort of functioning of those families and their offspring deteriorates as they get exposed more and more to the kinds of social conditions in our society. And maybe it's through the involvement of an NFP type nurse working with those families that some of that deterioration in functioning that we see in second and third generations of immigrant families will be reduced. So the need is there. And I just know that from my conversation with nurses who are serving immigrant families, they are so eager to get help and so eager to take advantage of every opportunity that nurses help them link to, that it gives me some real hope for that segment of the population. Thank you.
Good afternoon. When you, if I heard you correctly, when you started NFP, I thought you said that you first targeted an area of rural whites, and then you wanted to see if the outcomes would be different, if you could replicate what you were doing with urban African Americans and urban Hispanics. So my question is, since you deal with, the gamut of poor people with these programs throughout this country, what differences, if any, do you see among those three groups of rural whites, urban blacks, and Hispanics in terms of their problems and how to deal with those problems?
Thank you for that question. It's the reassuring message, I think, is that many of the kinds of both challenges and opportunities that families in poverty face are common, and they cut across racial and ethnic boundaries. I do think that there is some uniqueness about, as I was mentioning before, about recent immigrant families, even if they're poor, not being drawn into some of the really damaging cycles of interpersonal violence, for example, some of the compromising conditions for supporting children's development are there. But when I think about the poor whites in our Elmira trial, when I think about the poor blacks in our Memphis trial, I think about the sort of racially and ethnically diverse population in our Denver trial, it's hard for me to say there is something truly unique about these populations. And what I do need to say is that the program has been adapted, especially for Hispanic families, where the materials have all been translated into Spanish. There is a deep commitment to the program's adaptation to the cultural beliefs and the family's structure that may be more unique in particular ethnic or racial groups. But the challenges of living in poverty and having intergenerational stressors and histories of maltreatment create some commonalities among poor people in our society, some deep commonalities.
Good afternoon. So you had mentioned earlier about receiving a scholarship to go to school. So I'm wondering if you have any insight about your organization or institutions that are recruiting more women of color into nurse midwifery programs or nursing programs at all to kind of reduce that barrier of not welcoming people into the home when they don't look like them.
Yes. Well, first of all, thank you for that question. And I believe that we really do need to do an even better job of recruiting nurses of color into the NFP program. I do believe that there's an opportunity that's untapped for us to link to schools of nursing, to educate young nurses who are going through education about their opportunities to serve in this way, to give back to their communities. I don't think we've done that well enough yet. I do need to say something. This piece, though, you heard me say, but I don't think I elaborated on this, that in our Denver trial we systematically compared the relative impact of the program delivered by community health workers versus bachelor's prepared nurses. And what we found was that nurses produced effects that were roughly twice as large and more enduring than community health workers. And the basic explanation for those differences is that families were opening their doors more frequently to nurses than people from the community. And even if you adjust statistically in the analyses for dosage of the program received, nurses were still producing larger effects than their paraprofessional counterparts. So I think that there is something special about nursing and about the reputation that nurses bring to the community and with individual families. And when we think about this particular program, at least, where we're talking about what does this back pain mean? What's it going to be like to care for a vulnerable newborn? What does this symptom that I'm having, how do I interpret that? Nurses have credibility in being able to address those kinds of issues. And I think it's crucial for nurses, to have nurses doing this work because of the legitimacy, the credibility, and the openness on the part of mothers and other family members to get that kind of expert advice. So we do need to do what you're suggesting. Let's get more minority nurses into the workforce. Let's figure out what needs to be done earlier in nurse education to do that. Let's find those nurses who are really committed, those young nurses who are just entering nursing school who want to serve their communities. Let's align with them. We have wonderful nurses at Metro Health, and I think we should be asking them about how to address the question you just raised. So thank you for that.
I heard the Health Commissioner of Baltimore speak, similar topic. I think home visits are great. One of the things in this Baltimore, this great medical city, people were making their appointments. People were not making their clinic appointments. I think it's somewhat related. The poor patient is said, well, you're complicated. We want you to see Dr. Jones on Friday at 10 o'clock, but they don't have a method to get there. So their numbers with this great healthcare system in Baltimore were very bad as far as infant mortality. Is that a component of getting the people to those specialists that they might need?
Yeah, great question. I think that, I think in some ways we need to redefine what primary care is all about. And I think we need to be thinking about, especially with vulnerable, low-income patients, we need to be thinking about how do we really address all of their needs to make sure that they can obtain office-based care, but also the other kinds of services needed to reduce those stressors that interfere with their health and well-being. And I do think that I can tell you that in our programs, nurses have thought deeply about issues of access, issues of transportation. There is here in Cleveland a community advisory board that is designed to support the program. In fact, this community advisory concept is present across the nation. But the basic purpose is to think through what are the common needs of the population we are serving, and how can we have some assurance that those common needs are going to be addressed. And it includes things like getting transportation. It's insufficient, we think, simply for a primary care provider to run through a checklist and make a referral for another service. I mean, that's an important step in the right direction, but we think it's insufficient. We need somebody who really understands those factors that this mother has to contend with in getting herself and getting her baby across town to obtain care. And we can imagine a whole host of similar kinds of situations. That's why we need nurses in the front lines of all of this to orchestrate community responses to the needs of this family. Yes.
Okay, so I just have a question about the work of the nurses. So it appears from your work that you have low attrition among the nurses. So given the fact that the nurses are going into these high trauma neighborhoods, what mechanisms have you put in place to help the nurses deal with all that mental health and trauma that they're experiencing on a daily basis?
Thank you for that question. You know something, are these questions great or what? Thank you so much. This is so terrific. Thank you for that. This is really hard work, first of all. And you've highlighted an issue that we take very seriously. There's a lot of secondary trauma that nurses experience when they walk into a home and they see a child having not just the child of this mother, but other children in the family being at risk, or the mother having experienced intimate partner violence, or all of this is traumatic. And there are several mechanisms in place within the team to help reduce that. And honestly, I'm not sure that we've got it sewn up, but here are some things that are being done to address the very issue that you talk about. One of them is that there are regular case conferences where the nurses come together to discuss the most challenging cases and what they're doing to address their needs. There is individual reflective supervision between the nurse and her supervisor, where the nurse is attuned to the possibility that this nurse may be developing some anxiety or depression or trauma resulting from her experiences. In some cases, there are mental health workers who have been assigned to the teams not only to address them, to make sure that the mental health needs of the mothers and children are being addressed, but also to address the mental health needs of the team. Is that enough? Sometimes not. And sometimes we do have nurse turnover. And by the way, we had nurse turnover. In our original Elmira trial, we had all the same nurses working in the program. In the Memphis trial, we had turnover. Part of it was just competition, wage competition. Local hospitals could pay these nurses more than the Shelby County Health Department could pay them. So there is turnover, and that actually, I was holding my breath in the middle of our Memphis trial because I was concerned about turnover. But the fact that we see replicated effects in spite of these turnovers is reassuring. And we're thinking deeply about how we manage those kinds of transitions so that families are not further traumatized by nurses leaving. We should raise this issue with the Metro Health team to see what we can, whether I've hit the highlights or not.
That's why I asked. I've spoken to some of the nurses, and just hearing the stories, I was just wondering how that works.
Yeah. Well, we're on it, but whether we're on it enough, I'm not entirely sure. Thank you.
David, thanks again for being here today. Many people in this room and many people throughout our community participated in a community-wide read of Matthew Desmond's book, Evicted, which I imagine you've at least somewhat familiar with.
Yeah.
Eviction afflicts the communities that you're talking about serving a great deal and makes home visits a little bit challenging.
Absolutely.
I wonder if you could talk about how your programs have dealt with that in different communities.
Yeah, that's a terrific question. Let me. There are many layers in the response to that question. First of all, we have an unacceptably large number of mothers who are essentially homeless. They may be couch surfing with friends or relatives, and they may also feel uncomfortable about having a nurse come into their household when it's not really their space. So it creates a fundamental challenge in delivering the program to this very high-risk segment of the population. In those cases, nurses will meet with mothers wherever they will feel comfortable. It could be the library, it could be McDonald's, it could be the community health center. That's one thing. In Northumberland County in Pennsylvania, nurses were visiting mothers who were an example is a mother was living in a car and parked under a bridge. They were feeling that the rates of the limitations in housing were unacceptable. So they went together with a local church and a bank to build housing for NFP mothers and victims of domestic violence in their communities. Nurses, once they understand the needs of this population, become fierce advocates for their needs in their communities and saying, we as a community need to do more of this. And community advisory boards can play a role in that as well. So I'm not saying that that's the solution. That's not as simple as that. It's obviously a challenge, but it's not as if the nurses or the communities where the organizations where the program is being delivered ignore this issue. They're tuned into it, but it requires thoughtful community response. Yeah, thank you.
Hi, David. Thank you again for taking the time last night at our annual meeting and again throughout the morning today and currently for sharing your story with us and the great word of Nurse-Family Partnership. Given the audience in the room, we've got folks from philanthropy, we have folks from healthcare, from the county, from city government, from all sorts of sectors. I'm curious, based on your experience elsewhere, what are the things that a diverse group of people, of public stakeholders, can do to support this type of program and sustaining it moving forward? And where have there been barriers? What are some things that we should collectively be looking out for that we can address proactively?
Thank you for that question. First of all, I think that it's critical that key stakeholders understand the potential of the program, one. Two, I think that it's critical that we understand how access to needed basic services can compromise the nurse's ability to help parents protect their babies and protect themselves. And I think that there's nobody better positioned to really identify those challenges than the nurses on the ground, because they are there. It's not some 30,000-foot kind of examination of data saying we need more of this or that. The nurses can play a role in guiding those community discussions. And I think that bringing together some of these key stakeholders on a regular basis to reflect on the challenges that vulnerable families are experiencing is a critical part of the solution. And again, it's one of the reasons I'm really optimistic about what you folks are doing in Cleveland. It's because you really seem to have this shared commitment. It's really quite remarkable. Thank you.
Great job. Thank you so much. Today at the City Club of Cleveland, we're enjoying a forum with Dr. David Olds, founder of the Nurse Family Partnership and director of the Prevention Research Center for Family and Child Health at the University of Colorado in Denver. Today's forum is part of our Resilient Families series, sponsored by the St. Luke's Foundation and the William J. and Dorothy K. O'Neill Foundation. Additional support for today's program is provided by the Mount Sinai Healthcare Foundation. We appreciate all of you for your support and your work in this area. Thank you very much. Community partners for our forum today include First Year Cleveland, Neighborhood Family Practice, and the Schubert Center for Child Studies at Case Western Reserve University. Our hospitality partner is the Metropolitan at the 9 Hotel. Thank you all for your partnership. Additionally, we welcome guests at a table hosted by the Metro Health System. Thank you for joining us. That brings us to the end of our program today. Thank you, Dr. Olds. Thank you, ladies and gentlemen. Have a wonderful Father's Day and a great weekend. This forum is now adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org. Production and distribution of City Club forums on IdeaStream are made possible by the generous support of PNC and the Raskin Family Fund, with additional funding from Robert Conrad, Cleveland State University, the Chautauqua Institution, the Cleveland Clinic, and the United Black Fund of Greater Cleveland Incorporated.